Okay, this is a 36-year-old male patient. Basically had occasional tingling, numbness, claudication pain, walking distance less than 500 meters, pain in mobility, and gradually progressive symptoms. And that's the neurology. Neurology is intact. And that's the X-ray. You can see that there's a lytic, almost grade 2 spondylolisthesis. And that's flexion extension X-rays, and you can see that's the MRI. And yeah, MRI is seen like that, but there was basically it's a dynamic compression. You just need to reduce the listhesis and fuse this. You don't need to do any decompression. Okay, so this is very important when it comes to robot positioning the patient, and securing the patient to the table is very, very important, because you can have motion errors, which is the most common error which you can get in robots. Dr. Dinesh, how do you take care of avoiding these motion errors by positioning?
So I think it depends on what sort of system you're doing.
So we're using MISSAB.
Yeah, so I've used both the floor-mounted and table-mounted.
Yeah.
So if you're using the table-mounted like
yes.
MISSAB, then you need to strap the patient.
Yes.
Because if the patient coughs or moves, the robot cannot detect the change. And you have to redo everything.
Yes.
You have to
re-register, everything you have
But
to
with the floor-mounted system, this is less of a problem because it is navigation-based. So you have that tracker on the iliac crest, so even if the patient moves, it sort of knows that it has moved.
Yeah, Bauk is using the floor-mounted robot.
So that's the advantage, rightly said. So we put a dynamic reference-based array on the iliac crest.
Yeah.
So basically, in true sense, the robot maintains the navigational integrity. So even with the movement, even with this thing. So again, if you are using like pre-op CT, so some people, they use pre-op CT with the robot. So again, that is a problem because the anatomy changes while positioning this thing. So again, one has to be very careful whether the pre-op CT, suppose if it is a flexible, the problem, then the whole thing changes when you position the patient. So one has to be very careful about this thing.
So rightly said, these are two types of robots. One is, this is the table-mounted robot. That's the Mesorex from Medtronics. And we have XLS from Globus, which is a floor-mounted one. And XLS is totally dependent on navigation. And Mesorex has its own artificial intelligence. And the navigation is just an add-on where it gives you a visual feedback. Otherwise, it has got his own artificial intelligence. And that's you can see that patient is strapped very well so that you avoid any movement of the patient while you do the surgery. And so these are the instruments, more like a navigation. These are all navigation trackers, and we will see one by one instruments in future slides. Okay, and that's the robot which we are using. That's the Mesorex one. That's the robotic arm, and this is the guide for the pedicle screws. That's the emergency switch. That frees the robotic arm movements, which you can manually move the arm, and once you lock it, the robot arm moves only when you give command through the software. That's the screen for surgeon. This is draped and sterile. You can control, plan, navigate through this screen. That's ET. Basically, it's 2 cameras through which the robot senses the movement, all the topography, and 3D defined scan is done through that. And robotic arm does have a few cameras here, like 3 to 4 cameras there, and that helps us in basically having a 3D defined scan in that. And that's the draping, which is specially made for Mesorex, and that's one of the most expensive part of this surgery, the drapes and the tracker. Ultimately, and these are the instruments mainly which you use. This is the navigation reference array, and this is the Shanspin bridge, which allows us to marry patient to the robot. And these are the connectors basically to have your O-arm spin and have patient register to the navigation. And these are navigation trackers and guide wires and tap and all that. And the tap it has a fixed length of 30 millimeters. It just crosses the pedicle, enters the posterior vertebral body, and stops there. Okay, so that is where you register your all equipments with the robotic navigation. And you can see that I'm nowhere in the scene, so that is where you save your time with these robotic arms. And that is where you are putting a PSIS shank spin. It allows to secure the robot to the patient. We call it as marrying the patient to the robot, and that's done in the PSIS. And you can use different types of clamps. If you are doing a open surgery, we have different kind of clamps. If you are doing a MIS, then you have this iliac screw, and that's the clamp which you can see, which ultimately connect with this shank spin bridge to the patient. So, Dr. Bauk, how do you ensure that the relationship between a robot and the patient stays with XLES?
So I rely on the intraoperative CT scan. So if I have to just do a minimally invasive TLIF for this thing, then we can get away with the pre-op CT scan. And so the Globus one is different from this thing. The Globus one also works with the simple X-rays also. So we may not need CT for Globus, so we can just take a fluoroscopic shoot, and then there is a tracker on the C-arm itself, and then we can...
because it's like a 2D nav.
It's a
2D navigation.
2D navigation, and then robot can work on that. But if we are using the 3D navigation, pre-op CT scan, then again, this thing, we just confirm it with the help of a C-arm first, and we ensure that the integrity is there. But if I'm using an intraoperative CT scan, then there is no need to check all these things, and it is everything
so
is there.
if you are having a scan and plan workflow, that you are doing a preoperative CT scan and you are registering patient intraoperatively, does XLES registers automatically, or you have to do it manually?
So for Excelsius, you have, it can register the O-arm scan, but there's an array that you need to place onto the patient so that the O-arm scan can talk to the Excelsius robotic system. Yeah. You can do it also for this muscle.
So that's the navigation reference frame, and then you have to again marry your navigation to the robot. That we will do in the next step. So it has got again a tracker which is held on to the robotic arm, and video is slow because I had to present for 30 minutes. I thought, what will we present? So it will keep on running.
I'll
So
ask you a question. Some centers have stopped marrying the robot to the patient.
yeah.
They've skipped this step. Have you tried it?
So we have tried in cervical spine.
Yes,
Because
you
there
can't.
you
Yes,
can't do it.
yes.
So you fix ultimately your robot and the patient very firmly, and then you just don't use any pins or
What's been
any
your experience
trackers.
so
Yes.
far? Okay.
It's okay. So these are the clamps which you can use for different types of clamps which you can use for marrying the robot. So these are spinous process clamps, and there are double clamps also, and this is the clamp bridge which actually allows you to firmly secure these clamps, because these clamps can be combined and have a firm fixation to the spinous process. And that's now you will have a we call it as a 3D fine scan, because robot has to know where is the patient and where are the other instruments, and whenever you do this you have to move away from the patient so that it takes 5 shots, photos, and then it forms ultimately a 3D image or a topography of a patient. And it takes 5 shoots, and these are the cameras which help us to take the shoots. It's no radiation at all, and that's how your 3D topography is seen. Now we are again marrying the navigation to the robot. So you just fix the tracker and take a snapshot from a nav camera, and then the navigation is set up for the surgery. And after this, now registering the patient, taking a 3D image through arm. For that, you have a different kind of tracker which we are soon going to fix it. And before that, you have to tell the robot in which angle, basically a coplanar view has to be done with the snapshot. And that's the tracker, which it has got 4 balls. And with that, you register the patient with the O-arm scan. And this tracker goes and sits in the same coplanar way where you had already told the robot by using your chicken leg. And it has to be as close as to the patient, otherwise your errors can increase. So you more closer to the patient, the accuracy is better. And if you see that it's going into that coplanar way where your vertebral bodies are positioned. Okay, so now we bring in the O-arm. So you drape. So O-arm coming in, you take a spin, and so then you start basically planning. So the planning process involves, this is, first you mark the area of interest in AP and lateral. This was done on a dummy model. This is not the same patients, because once you have through the case, you cannot do the planning process of this part. So we did it afterwards. So this is how, and then you do a segmentation, and these are the segmentation lines. You take them parallel to the end plates, and the best part of the robot is it registers each vertebra separately. Even if you do a interbody work, the registration doesn't change. It doesn't change, because with the change of a position also, the vertebral body is registered separately. But then with the nav guided robots, if you do a interbody work first, then you will have to re-register again. So that's the best part of this, that you can do interbody work first and then put in your screws or guide wires. These are O-arm images, but this is a image of a dummy. Yeah. So, but then these are the O-arm images. But then, yeah. So you will see exactly the patient images in a while, and you do segment. If you have to do L4-5, you just segment L4-5 and maybe one above and one below. That increases your accuracy. Because O-arm would have taken 5-6 levels. Once you mark your area of interest, it just focuses on those 2 vertebrae. So then you label whether it is a lumbar spine or it's a thoracic spine, and then just you label one vertebra, L4. It basically numbers itself depending on that. The lower vertebra is labeled L5 and above is labeled L3. And you can change the rotation for your planning purpose. It makes your life easier. So make it dead lateral and dead in basically the coronal images and axial images. So, and then you take the center point and then start the planning process.
Can I ask, do you usually do the pre-op planning, or do you do a scan and plan?
No, scan and plan.
Scan and plan.
Mostly because we found that with scan and pre-op planning, usually with the deformities, it really makes difficult. But with O-arm, we have found the accuracy rate has been much better than doing a pre-operative scan. So you just plan your screws, everything, the diameter, length, and you can run through your planning in all the 3 planes, in axial, in sagittal, and in coronal images. And you just see that your pedicle screws are positioned. And then here you can see how much inside you want to go, whether you want to give lordosis, whether you want to give kyphosis, whether you want to keep them in one line so that you don't juggle with your rod so that you can plan your screws perfectly, and you can also plan. I'll show you how much angle you, and this one which you see there, that's the planning for the tube. So tube docking also is done through the robot, and after that there is no radiation at all for the surgeon for MI surgeries in this. So the interbody planning is done through that, and you can see that the screws are planned, and you run through each vertebra. It just takes around 5 minutes to plan around 4 to 8 screws. And that's the tube docking planning, you can see. So basically, I do a tubular MIS TLIF. So I plan the trajectory of the tube also through the robot, and I place in my guide wire, and then the dilators go on it. That is where you try to reduce radiation as much as possible to you and your team. So that's what I was talking. So if you see, you can see the alignment of the rods, and if you change the angulation, the rod angulation also changes. So that's how you see in deformities, and you can see that, you can see the skin markings also, and you can plan the skin incisions, how much far you want to go from the midline. If you don't want to, like, if you're doing a TLIF, you want to have a tube incision and the screw incision same incision. So then you plan your screw little, not in a collinear with the pedicle, to plan it in little straight, so that you can dock your tube also through the same incision. So that's what you can do. So so that is the planning process, and then after that the robot just guides you to go in and dock your tubes. So it also shows you that if your screws are going to touch each other. And now what I do is, because it's a very delicate surgery, because motion error is the one error which is very, very common, and that ultimately takes away the accuracy of the robot. So what I do is, I mark my skin incisions first, and then take out the robotic arm, take the skin incisions into the deep fascia, and then bring in robotic arm again and do that. So this is what my fellow is right now marking the skin incisions there. So for all the 4 skin incisions are marked. And sorry. So if you see, if I am doing a multi-level thing, I would like to have my skin incisions also in one line. Otherwise, you will ultimately end up struggling with your rod, and then you can catch deep fascia if they are not in one line, and patient ends up having a lot of post-operative pain in these patients. You want to comment something?
Yeah, I think this is one of the advantages not many people talk about, that you can plan your incisions. Everything
can be planned. So this is the stage where I enter, and then now we are drilling, and drilling just takes 15 seconds for each screws, and you have different kind of this is the sleeve, and you have a dilator.
So you have to use this drill, because this one doesn't cause skiving.
So basically it's a high-speed drill connected to a Midas burr, and initial phase when we installed robot, that in 2019, in India the high-speed burr was not available. So we had a lot of issues with skiving at that time. Bauk?
Also, this is very important that you don't put any pressure.
Yes.
So it should be, free,
just free
for the drill movement of the drill. Otherwise, you will change the anatomy.
It's like 2 fingers, soft touch.
Soft touch. The other thing with the Excelsius one is that it has got a knife also, which goes through
there is a knife in this also, but then I don't use that, because to cut the deep fascia with that, your robotic arm moves sometimes, and that is why I tend to take away robotic arm and have good generous skin incision with deep fascia, but because ultimately the post-operative pain, if you don't cut the deep fascia, is really troublesome. And that's the guide for the guide wire. And just put in guide wires. You can use a guide wireless technique also. You can use, but if you, then you will have to use the navigable Metronic screws for that. Then it becomes one of the restrictions. So here with guide wire, we can use any screws you want. You just put in your guide wires.
But you won't be able to see the screw going in, right?
Yes, you cannot navigate the screws. But now soon we are going to have all sort of Indian screws which can be navigable.
But I think they can make the custom guide, custom the screwdrivers for you.
So
No, you can if you use the Metronic screws.
you can, you have to use the Metronic screws.
They don't allow us to use
Because
the other screws.
because the optical markers, they are meant for the Metronics one only.
And the dimension, ultimately the navigation is all about relationship between your screw and the screwdriver, and what is the length, what is the depth, the diameter, everything matters. So you can copy and do a screw holder for that, and then you can navigate your screws.
But you can do that here. I think in Singapore we can't.
So you cannot. So that's the knife you can see. Wow. So so that's the knife, which is the robotic guided one. That's a long knife. And you have two kinds of tools, short tools and long tools. You always try to use short tools because that decreases your skiving potential. So that's again drilling. You can see I'm just holding it like a pen, and it's just a soft touch. And again, that's the dilator for the guide wire. And I'm just using CAM to show for this video purpose. So those are the wires which I've gone in. And in lateral, you see that one of the guide wires is short because it just drills that 30 millimeters only. After that, it's a vertebral body, it just guide wire slides in. And then you dock your tube through the robot, and then you just do the same TLIF. I think we are over with the time. I'll just finish in 1 minute.
Have you encountered situations where sometimes the nav and robotic thing do not match?
Yes, that happens. Not sometimes. Lot of times it does happen. And then the one way is you can again take one more spin if you are not confident. But then the good thing with robot is unless the nav is not matching, but then the robot had registered it properly because it is independent of navigation. Usually it is right. But then as a surgeon, because that visual feedback is not giving you the right direction or the right perception, you always tend to re-register and do it properly.
I found an issue with the nav in the sense that how you face it to the camera can
definitely the rotation, because that also changes a few millimeters up and down.
I hope they fix it. I think it can be fixed. It's probably just a calculation.
Even the OT light, we have seen that the OT light, the intensity of the OT light also affects
navigation because it's optical reader.
Also, if you are doing open surgery, if you're putting the open screws, then it becomes a challenge because the soft tissue, the moment you retract, your anatomy changes.
So definitely my maximum usage of robot is for MIS. If I am using open, I am doing open cases, I use navigation, OM navigation. I don't try to use robot because the soft tissue pressure always changes your planning. And like Vidyadhar is not here, our robotic man. So he does open surgeries also through robot, but for every case, they take extra incisions onto the skin. And they're putting those extra incisions and then putting the screws and do midline surgeries. But then I feel that's like too much. And you have many incisions, and I'm not very confident about that skin in between the midline incision and those lateral incisions. So that's the final picture. You can see very well medialized screws and nicely placed screws. Okay. So the real advantage is one is the radiation. That's one of the most. It's if you are using a navigable screws, for you as a surgeon it is nil. For you as a surgeon it is complete nil, and for the For whole party, when you take warm spins, everybody goes out of the operation theatre. So for them also, it's almost nil. Yes, for the patient, because OARM is a very low dose radiation, it's lesser than CARM actually. When you take multiple shoots for putting these percutaneous pedicle screws, the OARM spin, one spin is lesser than those shots. So one is radiation. The other thing is in difficult cases, in dysplastic pedicles, narrow pedicles, and you can plan it very well and robot executes it very well. And once your team is trained, maybe the anesthesia time might remain same because the robot setup, draping, warm coming and going out, planning takes time. But as a surgeon, for me, my surgical time reduces by more than half. Because each screw just takes 15 seconds to 30 seconds. And that reduces quite a bit of time for surgeon. Definitely, it's more accurate. Definitely more accurate. And the best part is the planning. The way you want to plan and do your surgery, you can execute it to the same planning process.
So biomechanically, you can also take the advantage because you can take the maximum length of the screw. In a dysplastic pedicle, you can plan already the maximum length of the screw, the maximum diameter of the screw, and with the help of the robot, you can maintain that navigational integrity that you will be able to put that into this thing.
And you can take anterior purchases.
So in high-grade listhesis on this thing, then you are taking the maximum biomechanical advantage of that particular screw.
I found actually the real big advantage, having used the robot for quite a while now, is that you can reproduce the results. Once you know the system well, you can reproduce the results and your juniors can put in the screws. So, and it's better than anything you would have done freehand. And I think that's possibly going to be the change in the future.
So that's the another case. This is a TLIF, transcambin fusion. So again, we all know that for doing a transcambin fusion, you require a lot of radiation, more than MIS TLIF actually. But then with robot, you can plan everything again, including your the trajectory of the cage, because in transcambin fusion, the cage placement is very, very important. And your needle docking is again very important. So you can plan your needle docking also through the robot and execute it perfectly.
And do you put the endoscope with the robot or
so
you just use the
initial few cases I did because I was not very confident of exiting route. But then after some time, I'm not using any scope into the tube. I just do it blindly now.
Also,